Hello and welcome. Welcome to Learning Thursdays. I am Patty Corbett Ward, and I am a trainer in the OASAS Learning and Development Unit in Albany. I will be your host for this Learning Thursday presentation, which is entitled Clinical Screening and Assessment of the Impaired Driving Offender. Your presenters are Bridget Hartman DeCenzo and John Reddy, both from the Learning and Development Unit as well. They will be here in a few moments to introduce themselves to you, as well as the history of the training. In the interim, I would like to provide a cursory overview of the Learning Thursdays educational series. One goal of Learning Thursdays is to support and help advance the educational and professional competency development of the treatment, prevention, and recovery workforce, a competency being comprised of knowledge, skills, and attitudes specific to a task. In part, we do this by offering monthly presentations that are current and relevant. The presentation you will be watching today is Clinical Screening and Assessment of the Impaired Driving Offender. As always, if you have any questions, feel free to send them to the mailbox noted on the slide in front of you. All that being said, John and Bridget will take over from here. I will be back at the end of the training to talk to you, and enjoy the training. John and Bridget, thank you and welcome.
Welcome. My name is John Reddy. I'm a training specialist for the New York State Office of Alcoholism and Substance Abuse Services in the Learning and Development Unit, and I will be one of your presenters for today. I am also a CASAC. I was credentialed back in 1981, and I'm also a licensed clinical social worker currently in private practice. My experience with this population goes back to Saratoga County. I was doing drinking driver evaluations back in 1978, a long time ago. So I'm happy to be here. Thanks.
Welcome everyone. My name is Bridget Hartman DeCenzo. I am the manager of the Learning and Development Unit. I've been working on the Impaired Driving Training Initiative since 2009. And prior to my work at OASAS, I did conduct impaired driving assessments in the field. So we'll get started now. The goal of this training is to improve the quality, the consistency, and the efficiency of clinical services to impaired driving offenders across New York State. And we are hoping that you will walk away from this training with the ability to discuss the rationale for standardizing the provision of clinical services to impaired driving clients. You should be able to list 3 risk factors for impaired driving recidivism. And you should be able to describe the use of various screening measures and biopsychosocial assessment procedures as they apply to the impaired driving client. So to give you a little bit of history as to why we created this training, I just wanted to explain to you how this came to be. So back in 2006, OASAS was given the legislative authority to oversee the list of providers who are approved to treat impaired driving offenders in New York State. So that list consists of state ed licensed clinical private practitioners, in addition to staff that work at OASAS certified programs, some OMH programs, some VA programs, and also Indian Health Services programs. And what came to light for us was that there was a need for there to be standardized clinical practices for impaired driving offenders. And so back in 2009, we received a Governor's Traffic Safety Committee grant, and we formalized our working relationship with the Department of Motor Vehicles. And we started to work on 4 main projects with the ultimate goal of reducing impaired driving recidivism. So we issued standards for clinical services provided to individuals arrested for an impaired driving offense. We developed this training. We also developed the impaired driver system and the impaired driver program curriculum, which used to be known as the drinking driver program. That curriculum was revised. So in 2010, the standards for clinical services were issued. Basically what happened was we convened a group of subject matter experts, and we developed the standards that are based on best practices for impaired driving offenders. And the standards are the guidelines that you should follow as you work with impaired driving offenders. So the standards were issued back in 2010, and we asked all of the programs that were on the list at that time to attest to the fact that they would follow the standards. So if you're watching this webcast now, it's very likely that your program has attested to following the clinical standards, and this is the guideline that you should use going forward as you work with impaired driving offenders. And this is the legal basis for why the standards were developed. So as I had referenced before, we were given legislative authority to oversee the list of people who basically screen, assess, and/or treat impaired driving offenders in New York State. So this is the required training that all OASAS Certified 822 programs, OMH, VA, and IHS representatives, and state education licensed professionals must attend. All staff have to be trained to provide this service. And basically, before you're approved to use the impaired driver system, you have to watch this webcast and you'll have to pass a 10-question quiz. And that will give you permission to the impaired driver system as long as you're qualified. The impaired driver system, I'm going to get into more about this later on in the training, but basically it's an electronic reporting system. So for those of you who have been in the field for a while, you may remember the old DS-449 form that was required by the Department of Motor Vehicles. The impaired driver system has replaced that DS-449 form. So it's a web-based data collection, tracking, and reporting application. And OASAS and DMV worked very closely together over many years to develop this system. OASAS approved providers, the impaired driver program directors and staff, the New York State Department of Motor Vehicles and OASAS all use this system. It does require a special consent form, which I will talk with you about a little bit later on. And again, the system does replace the DS-449 form. The DMV is no longer accepting that form. This system is tied to relicensing, so it's extremely important that it's used and updated on a regular basis. So the drinking driver program became the impaired driver program, or the IDP, effective December of 2015. And the reasoning for this was, as you know, impaired driving is not just drinking and driving. It's really drinking and driving or driving under the influence of substances. So there were many recommendations to change the name, and the Department of Motor Vehicles decided to do that in December of 2015. So the last component to our work with DMV under the GTSC grant was to revise the curriculum for the impaired driver program. So the impaired driver program, or the IDP, is overseen by the Department of Motor Vehicles. The curriculum that's now used is an evidence-based curriculum called the Prime for Life. And basically, people who go into the impaired driver program are court mandated. They're eligible as defined by the Department of Motor Vehicles. And it's important to highlight here that clinicians can't refer to the impaired driver program. The Prime for Life curriculum is a 12-hour evidence-based curriculum. The impaired driver program in total equals 16 hours. The first 4 hours are specific to New York State specific law and traffic safety related information. So if you're interested in learning more about Prime for Life, you can go to this website at the bottom, www.primeforlife.org, for more information about Prime for Life. So now I'm going to hand it over to John, and he's going to talk with you a little bit about the scope of the problem.
Thanks, Bridget. We'll be focusing on both national and New York State statistics for this, some statistics that we've gathered from various sources. Nationally, about 25% percent of all drivers involved in fatal DWI crashes have a past DWI conviction. That will come in when we talk about assessment as an issue. The average impaired driver has driven intoxicated 80 times prior to their first arrest. And I think it's important to bear in mind for those of you that are doing assessments that it's not unusual for individuals to come in and report to us that it's their first time drinking and driving or using drugs while driving. And although that's possible, it's highly improbable, given this particular statistic from the FBI. The scope of the problem, each day in the U.S., people drive intoxicated almost 300,000 times, but fewer than 4,000 of them are arrested. In 2013 alone, 10,076 people in the U.S. were killed in alcohol-related crashes. That's one every 52 minutes, and approximately 30 people a day. That's from the Center of Disease Control. Taking it to a little closer to home, to New York State, in 2012 there were 51,255 impaired driving-related arrests, and from December 18th, 2009 until July 22nd, 2013, there were 3,096 Leandra's Laws arrests reported in the New York State Division of Criminal Justice Services. You have a photograph there of Leandra, which we added to the presentation. This was the little girl that was killed in a van in a crash in Manhattan back in October of 2009. At that time, she was one of 7 children in that van that was being driven by a friend of hers' mom. And she, as I said, was killed in that crash. And at that point, her father started to work on Leandra's Law and championed that new law coming into New York State. And it was made law 2 months later in December of 2009. Leandra's Law, some of the specifics about that: first-time offenders driving while intoxicated with a BAC of 0.08 or higher, or impaired by drugs with a child younger than 16 years old in the vehicle may be charged with a Class E felony, punishable by up to 4 years in state prison. Courts must order those convicted DWI individuals with a child in the vehicle to install and maintain an ignition interlock for any vehicle owned or operated by that individual for a period of at least 6 months and possibly longer. And that includes the impaired driver paying for that device, installation of that device, and also the monthly maintenance fee of that device. Individuals charged with driving, again, with the BAC over a 0.08 or greater automatically have their license suspended pending prosecution. Individuals driving that caused the death of a child under the age of 16 may be charged with a Class B felony, punishable by up to 25 years in state prison. And if that driver causes a serious physical injury to a child in a vehicle, that individual can be charged with a Class C felony, punishable up to 15 years in state prison. In addition, anyone in the position of a parent, guardian, or custodian who's legally responsible for that child is also reported to the statewide Central Registry for Child Abuse and Maltreatment by the arresting agency. So that gives you some basic information about Leandra's Law. In addition, some specific laws in New York State. There's Vince's Law, which was named after a gentleman from Syracuse, 84-year-old gentleman that was killed in 2011 on his way to church by an impaired driver. At that time, that impaired driver was awaiting sentencing for his 5th DWI conviction at the time of the crash. So what that looks like under the law is that a person with 3 or more DWIs within a 15-year period could face up to 7 years in prison and a fine up to $10,000 for the fourth offense. In addition, the governor released a press release back in June of 2015 that announced more than 7,500 dangerous drivers were kept off the road due to tougher regulations that were enacted in New York State back in September of 2012. DMV, as a result, permanently denied relicensing of 3,942 individuals because they either had 5 or more alcohol or drug-related driving convictions in their lifetime, or 3 or 4 or drug-related convictions in the last 25 years, plus at least 1 other serious driving offense during that period. So that has had a very powerful effect on repeat offenders. Some additional national statistics, 31% of all traffic fatalities in 2013 were killed by alcohol-related crashes. The cost, as you can see, exceeds $59 billion. That was in 2014. Approximately 70% of alcohol-impaired driving fatalities involved a driver with a blood alcohol count at 0.15 or more. We'll be spending some more time on that when we get to the DSM-5. And in addition, when drivers are looked at with the BAC of 0.15 or higher, they're 9 times more likely to have a prior DWI conviction. Some risk factors for recidivism. I think as we look at these risk factors, I think it's important to be aware of them and know at the same time that you can't actually diagnose someone on risk factors. Some of those would include individuals who are non-Hispanic white males, approximately 35 years old or younger, individuals that are unmarried, 12 years or less of education, employed in non-white collar jobs. Again, we're back to BACs. Their BACs at the time of their first arrest tend to be approximately 0.18 or higher. Their driving history includes several moving violations, and they may have other legal problems that are non-motor vehicle related. One of the evidence-based practices that we would recommend that you used with impaired drivers is motivational interviewing, something that we have trained across the state over the past several years. MI was developed by Dr. William Miller back in 1983. It actually cut its teeth, so to speak, with impaired drivers when Dr. Miller wrote the first article in '93. The title of that was MI, Motivational Interviewing with Problem Drinkers. As I said, it is an evidence-based practice. To give you some information on that, after the second edition of the book came out in 2002, between 2002 and 2013, when the current edition of Motivational Interviewing came out, there were over 25,000 articles citing motivational interviewing and over 200 randomized clinical trials in print, mostly published during that period before MI3 was published, as I said, in 2013. As a result of that, for those of you that may have been trained in motivational interviewing prior to 2013, based on the first or second edition of the book, we certainly would recommend that you take a look at the third edition of the book because that particular edition, based on research, is a 90% rewrite of the second edition of the book. Another good resource is the motivationalinterviewing.org website to take a look at some of the research that's there. It does go back to 1983. There's also a short MI training that you can take on the addiction medicine, free educational series on the OASAS website. And we certainly highly recommend, as I said, that people get trained in MI. It's proven effective with this particular population. You basically need 2 things to do MI. You need a target behavior and you need ambivalence. And this population coming in for screening and assessments certainly come in with ambivalence most of the time. So at this point, I'll turn the presentation back over to Bridget.
Thanks, John. Okay, so why screening and assessment? Although strict sanctions are important in reducing the prevalence of impaired driving offenses, screening, assessment, and treatment, when appropriate, are also important factors in reducing recidivism. So we're hoping that you can help us reduce the impaired driver recidivism rates in New York State through your clinical process. So I find it helpful to differentiate the terms screening and assessment because I think that people get these terms confused a lot in our field. So screening is a process for evaluating the possible presence of a problem. So if you think about going to your doctor for your physical, oftentimes your blood pressure is checked. Your blood pressure is checked as a screening to indicate whether or not there could potentially be a heart problem going on. So if your blood pressure is high, that would be a red flag that would indicate to the physician or the nurse that you may need a further assessment to figure out if you do in fact have some sort of a heart problem. So you might get referred on for an EKG or a stress test, and that would be the assessment part. So assessment is a process for defining the nature of that problem, determining a diagnosis, and developing specific treatment recommendations. Same thing with our field. In some circumstances, people are just screened to determine whether or not there's a possibility that there may be a problem and that there may need to be an assessment. So why are we talking about screening impaired drivers today? Well, we're talking about screening impaired drivers because there are instances where the court specifically mandates a screening. 99% of the time, the court requires a clinical assessment, but we do find that there are some judges that will still mandate a screening. So obviously, in that case, there's a need for you to administer a screening tool. So there are problems with screening that we want to point out today. Obviously, screening tools are not foolproof. The best screening tools use direct and indirect questions, but then of course there's always the factor of the client not being forthright in disclosing what could be going on. So the solutions to the problem is basically using multiple sources of information or using multiple screening instruments. And that basically leads us into the multi-method approach for screening. So a former colleague of ours used to equate this to a screening on steroids, but best practice indicates that if you do have to screen an impaired driving offender, beyond the screening instrument, there are other things that you should do before a determination is made as to whether or not a person should go on for an assessment. Again, I just want to clarify because there can be confusion about this. The only time you need to screen an impaired driving offender is when a court mandates specifically a screening. So I'm going to walk you through these pieces of documentation that we need, and what you're going to find is the process is very similar for the assessment process as well. So the first thing that you need to do is you need to administer a screening tool. So this is a list of the screening tools that are approved by OASAS for the screening of impaired drivers. The RIASI, and the RIASI was developed specifically with impaired drivers in mind. There's the Audit, the MAST, the DAST, and the SSI-SA. This is not to say you can't utilize a different screening tool, but we would like you to talk with us about that before you utilize a different screening tool. The other thing I just want to mention is that if you need copies of any of these screening tools, OASAS can provide you with that information. At the end of this presentation, there is contact information that's listed so that you can contact us and request that material. The next thing that you'll need to do is you'll need to administer a urine drug screen. So the clinical standards are specific in stating that the urine drug screen must be a 7-panel drug screen, and it must also include the ETG test. The ETG test is a test for alcohol. Most labs do it in New York State, but not all labs in New York State will run an ETG test. So it is important that you do verify that the lab that you're using does test for ETG. The labs in New York State, use a cutoff of 500 nanograms per milliliter. So the ETG test is important because it can tell you if your client has ingested alcohol within the past 80 hours. It's a yes or no verification. There aren't levels involved. It's just a mere positive or negative. So we do have information on our website about the labs that are approved by New York State, and you can use this web link if you do need to locate a lab. The other document that we do require that you review is the abstract of driving record. So as you know, this is the official driving record from the Department of Motor Vehicles. When I was doing assessments in the field, I had to ask my clients to bring that information to me. The good news is that you no longer have to do that as long as you're using the Impaired Driver System. If you're authorized to use the Impaired Driver System, then you merely have to push a button and it's going to open up the person's driver's abstract. Obviously, this will not be the case if your client is from out of state. But for New York State residents that have New York State licenses, there will be an abstract of driving record. So basically this lists, it tells you all about the driver's license, it tells you the status of the license, any suspensions or revocations, any moving violations, accidents, or convictions. So this is a really important document. If you think back to what John was talking about with recidivism and the risk factors, one of the risk factors is individuals who have multiple moving violations. So even if your client has only had one impaired driving offense, if they do have a history of moving violations or suspensions, revocations, that is something to consider as you move forward in the screening or assessment process, because you do need to look at the driver's abstract during the assessment process as well. The other piece of documentation that we require is that you secure, or your client gives you some form of official documentation of the violation. So this comes by way of a ticket, or it could be an arrest report. We do understand that arrest reports can be difficult to obtain in certain jurisdictions. But the reason that we like for you to request this information and for you to review it is because it does give you more information about what happened. It tells you about what the charge was. It oftentimes is going to give you the BAC, which we all know our clients may not be forthcoming about. It's going to tell you what happened at the scene, why the person was pulled over. So again, when we think about a multi-method approach to screening and assessment, it makes a lot of sense that you would want this piece of documentation before you make the decision, before you make any decisions, really. We do understand that you know, there are circumstances where a client may not be able to provide it to you. What we ask in that scenario is that you document that the client was, you know, unable to supply that information, and that you feel that the client made many efforts and attempts to supply you with that information. So John is going to talk with us for a couple of minutes about BAC.
Thanks, Bridget. One of the nice things about the DSM-5 is that it does provide some guidance for us as far as blood alcohol content. Specifically under the area in the DSM-5 labeled diagnostic markers, it talks about BAC. And BAC levels can indicate tolerance and therefore may be considered a symptom of an alcohol use disorder, although it's important to not diagnose an individual on a high blood alcohol level. It is one of the criteria in the list that we'll go over in a few minutes. Specifically, as far as tolerance levels are concerned, As you know, you will have people coming in to see you for screening and assessments with a wide variety of blood alcohol levels. As I said, the DSM-5 does help us with some guidance. They say that individuals with a BAC between a 0.15 and a 0.20 who do not show signs of intoxication can be presumed to have acquired at least some degree of tolerance to alcohol. So that's significant. Again, the 0.15 up to a 0.20. Some individuals will report that they felt very intoxicated driving at that BAC. Other individuals that you assess and begin to question about this may state to you that they felt fine to drive and didn't really see that as a problem, which again is one area rating where you can actually pick up tolerance. The other clear indication that the DSM-5 sets out for us is individuals that are above a 0.20 BAC have tolerance, and non-tolerant individuals operating a motor vehicle at that blood alcohol level would be severely intoxicated, severely impaired. So again, 0.15 up to 0.20 if an individual doesn't show signs or doesn't feel intoxicated, and over a 0.20 is an indication of tolerance. And I think Bridget will talk about collateral contacts.
Okay. Yeah, when you refer to BAC, we all have examples of certain clients that we've had in the past that really just we'll never forget. And there was an instance one time where I was about ready to do a group session, and I just decided on that night that I was going to breathalyze everybody, and so I did. And there was one person in my group who blew a 0.2 something, and had I not breathalyzed him, I really don't know that I would have known he was under the influence of alcohol. It was quite shocking. So I think that, illustrates your point. So we'll finish up here with this section with the collateral contacts. It's extremely important for you to make a collateral contact, at least one. We suggest that you make at least 2 collateral contacts. And it's preferable if your collateral contacts can happen in a face-to-face setting. We do understand that's not always possible, but it's preferable. So this is a nice list of people or things such as records that you can consider as a collateral contact. So again, just kind of wrapping up this screening section, and not to beat a dead horse, but you're only going to do a screening when a judge mandates it. And these are the pieces of information that you should collect through your screening process before you make a decision about whether or not you feel that any red flags are raised enough to recommend that a person go on for an assessment. By and large, most of the time you're going to be doing a full assessment on impaired driving offenders. And John is going to talk about that.
One thing that I wanted to add as far as collateral contacts are concerned is the issue of working with family members, having family members come in as collateral contacts. I wanted to use an example that occurred probably 30 years up in Saratoga County. I was assessing an individual that had either 4 or 5 DWIs, and as part of the assessment, they were required to bring in a family member. He brought his wife in, who during that assessment insisted that there was not an alcohol problem in the family, insisted that the his drinking had not created problems for her or his children, and presented a very functional picture of the drinking. And I took that information as it was presented and continued with the assessment. Several months later, that spouse came in after the marriage had dissolved and reported that she was involved in a domestic violence situation with her husband. So it's important when interviewing family members to always keep in the forefront that you may be dealing with someone that has experienced intimate partner violence or domestic violence, and to keep that in mind because it can really influence what people may or may not be saying, family members. It's clear that if someone, for individuals that do have a substance use disorder, the rates of intimate partner violence are increased from the general population, and the rates are increased again if an individual has a substance use disorder and a gambling disorder on top of that. So again, just important information to bear in mind during your assessment process, especially when meeting with significant others, family members, loved ones. We will move on to the area of assessment. Bridget talked about screening, and a comprehensive assessment is conducted as a result of a screening, which may indicate that an assessment is necessary. As Bridget said, most of the time people will be coming in for assessments, referred in for assessments, and a comprehensive assessment is conducted if an individual has been referred or required to come in from a court in your county, Department of Motor Vehicles and Impaired Driver Program, and or their attorney. Those are some of the ways that people can come in. We did have a slide that Bridget presented on multi-method screening, and you can see this slide is different. It's multi-method assessment, and essentially the main difference here is number one, when you're doing a multi-method assessment, you're going to be moving away from using a screening instrument and doing a clinical interview, a clinical assessment, and a biopsychosocial history. So if you're, sometimes there's some confusion around this. If you are going to be doing an assessment on an individual, there's really no need to do a screening on them. You can move right forward with the formal assessment process, which will include, as you can see, the clinical interview to interview the biopsychosocial, urine drug screening with an ETG, review of the abstract, review of the arrest report, and as Bridget said, interviews with collateral sources. So all of those remain in place to assist with gaining accurate information from a number of sources. The comprehensive biopsychosocial assessment, when are clients referred for those assessments? A court may order an individual to undergo a formal substance use disorder assessment when an individual at arraignment is charged with or prior to sentencing is convicted of a violation of vehicle and traffic law 1192. Those numbers there represent a DWI, a DWAI, driving while ability impaired by drugs, a combination of driving while under the influence of alcohol and under the influence of drug, an aggravated DWI with a BAC of over 0.18, and lastly, as we talked about, aggravated driving while intoxicated with a child in the car under the age of 16. So within the previous 5 years, if they've been convicted of vehicle and traffic law violation 1192, like we said, or they've been convicted of vehicular assault or manslaughter, and within the previous 10 years, if that individual has 2 or more convictions or has any 2 vehicle assault or manslaughter charges, an assessment can be ordered. The next slide, a court may order an individual to undergo a formal substance use disorder assessment. In addition, again, if they have a violation of 1192 with a BAC of 0.15 or higher, or a violation of 1192-2A, which again is Leandra's law. So those are clearly set standards for people being referred in for assessment. As you know from the work that you're doing in the field, a biopsychosocial assessment will take the assessment to a deeper level and taking a look at that person's history. You're going to want to take a thorough alcohol, drug, and other substance use history. The best way to do that is to start when they started to use substances and work up to their current age, not to start at their current age and work backwards. You'll certainly have a better chance of getting an accurate view of any progression that's there if you start at the age when they started to use substances. In addition, to take a look at their legal and medical history. As far as legal and medical history are concerned, I certainly have a memory of working with one client where I asked him how many convictions he had, and he told me, and I later asked him how many arrests and convictions he had, and he gave me a different number. And I had said, well, you didn't give me that number the first time I asked you. And he said that, you didn't ask me how many times I was arrested. You asked me how many times I was convicted. So it's important to, when getting history, to both get rates of arrests and convictions. Take a look at, again, a person's educational and vocational history, how alcohol or substances may have created issues there. Family history is important. We'll talk about that as a risk factor. And also their social history and their use of leisure and recreational time. And again, this all, of course, is tied to their substance use. Some of the red flags for concern, if there's a family history of substance use disorders or mood disorders, people are at a higher risk. We had talked about blood alcohol level earlier, blood alcohol content, again, above a 0.15 is a red flag. Several other moving violations, which we talked about. Other alcohol drug-related convictions. Sometimes people will come in already currently involved in the legal system, possibly on probation or parole, or waiting to go to a court due to another charge. You will also have, at times, individuals that will be in the process of an evaluation with you that may incur another charge during the evaluation process. History of mood disorders or coping problems. Very often we'll see people relief drinking or using substances to relieve uncomfortable feelings with these kinds of issues. Individuals who enjoy taking risks, and individuals who see their impaired driving offense as bad luck is another sign of people not taking responsibility. It's a red flag of concern. So there's some other basic red flags. From there, what we would like to do is we would like to spend some time talking about the new DSM-5, which was published by the American Psychiatric Association in 2013. So we'll go through some of the basics in terms of substance use disorders. So basically, the DSM-5, what does it do? It drives treatment, access to treatment, helps us determine the level of care an individual needs. It also is important as far as reimbursement for services is concerned. And lastly, it's important that when diagnosing an individual, that if you do not have a DSM-5 substance use disorder diagnosis, and we'll talk about the criteria for that in a minute, that you cannot place that person in treatment without a diagnosis. This is something that we have seen occasionally across the state. It has been a problem where people have been recommended treatment without a diagnosis. So that's something important to consider and remember when you're diagnosing people. Some of the basic changes in the DSM-5, as you know, we moved to a basic number from the Roman numeral system. So we're using the number 5 at this point. It's thought that in the future, instead of having text revisions and so on, that it will follow sort of like the computer world, with revisions being the same kind of thing as far as a DSM 5.1 or 0.2, so revisions may go in that format. The whole substance use disorder spectrum has been changed. So now we're working within a spectrum as opposed to working with a substance use disorder of abuse or dependence. Those two qualifiers are gone, and we're now working in a single spectrum. And the other major change in the DSM-5 is that the multi-axle system has been removed. There's no longer 5 axes to diagnose on. And you have a picture here of some of the previous DSM books that go, interestingly enough, all the way back to 1952. DSM-1 was published in 1952. Some of the other basics, we talked about the abuse and dependence being replaced by a substance use disorder, and we'll talk about what those specifiers are. The DSM-5 includes 11 criteria. We will review those in a minute. It also rates severity. And one of the things that DSM-5 did through research is remove legal criteria as a criteria for a substance abuse problem. This initially did create some upset in the substance abuse field. Going back to the DSM-5 with research, one of the things that they took a look at is they took a look at a clinical sample of 663 individuals with diagnosed with a substance use disorder, all of whom had at least one arrest in their criteria. And the researchers removed that arrest from the criteria, and not one of those individuals lost their substance use disorder diagnosis. They all remained. They all continued to have a substance use disorder even though the legal involvement was removed. So it was thought that that could be removed, that it didn't serve that much of a purpose. So that's why that was removed. In addition, DSM-5 also added a criteria for craving. And that particular criteria, it's been said for a long time that craving is a difficult thing to measure, but if an individual has an addictive disorder, substance use disorder, that they're certainly craving that substance. So we believe that this is a good criteria to add. And interestingly enough, it was added based on genetic and brain studies. The diagnostic criteria that we were talking about, they're listed out here, and I'm just going to take a brief look at these. So in a 12-month period, 2 or more of the following criteria need to be met. So we'll go through each one, and then we'll take a look at how the criteria fall out as far as making a diagnosis. So during a 12-month period, 2 or more of the following criteria. Criteria 1, substance is often taken in a larger amount or over a longer period of time that was intended. 2, persistent desire or unsuccessful efforts to cut down or control their alcohol use. In this case, we're talking about alcohol. 3, a great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects, so hangovers, etc. And 4, craving or a strong desire or urge to use alcohol. So again, part of your assessment will be asking about craving, how often, when do people start to think about drinking or using drugs based on their pattern. Criteria 1 through 4 that I just went through, those basically represent impaired control. Those are the criteria that get at impaired control for the individual that's being assessed. Criteria 5 is recurring alcohol use resulting in failure to fulfill major role obligations at work, school, or home. And 6 is continued use despite having persistent or reoccurring social or interpersonal problems caused or exacerbated by the effects of alcohol. And 7, important social, occupational, and recreational activities are given up or reduced because of alcohol use. So the criteria numbers 5 through 7 that I just read indicate social impairment. So far we've talked about a grouping of impaired control. Now we've added social impairment. up to number 9, which is, let's see here, number 8, which is recurring alcohol use in situations which is physically hazardous, and 9, alcohol use is continued despite knowledge of having a persistent or recurring physical or psychological problem that is likely to have been caused or exacerbated by the use of alcohol. So we will add to our categorization with risky use. So criteria 8 and 9 represent risky use. And the final 2 criteria are criteria 10, which are tolerance, defined by either of the following: a need for markedly increased amounts of alcohol to achieve intoxication or desired effects, or B, a marked diminished effect in continued use of the same amount of alcohol. And last but not least, number 11 is withdrawal, as manifested by either of the following: the characteristic withdrawal syndrome for alcohol, in this case alcohol, we're talking about alcohol, or alcohol or a closely related substance is taken to either relieve or avoid withdrawal symptoms. So again, it's important to bear in mind that I was reviewing the criteria for alcohol. The DSM-5 does have 10 substances that are listed, so these criteria are looked at specifically across each one of those 10 categories. And again, the essential feature of a substance use disorder is going to be a cluster of cognitive, behavioral, and physiological symptoms, with that person continuing to use despite problems that substance or substances are creating. Interestingly enough, the criteria as far as severity are concerned are set at mild, moderate, and severe. So for an individual to have a mild substance use disorder, they would need to have 2 to 3 symptoms, 2 to 3 criteria met. For a moderate disorder, they would need to have the presence of 4 or 5 symptoms or criteria. And to have a severe substance use disorder diagnosed, they would need to have the presence of 6 or more symptoms or criteria met. So what DSM-5 did is it set a mild use disorder at a minimum of 2 symptoms, whereby in the old DSM-4, a person was able to be diagnosed with an abuse disorder with 1 symptom. It was thought that the way that the criteria are laid out in DSM-5, that 1 criteria was not sufficient enough to set the bar at for a substance use disorder, that it really needed to be set at a minimum of 2. So those give you the severity ratings. Again, you would need to have at least a mild substance use disorder to place someone in treatment. You would need at a minimum to have that diagnosis. In addition, the DSM-5 does put forward specifiers for us to take a look at in early remission, in sustained remission, on maintenance therapy, and in a controlled environment. Early remission occurs between 3 to 12 months when no criteria are met, with the exception of craving. And sustained remission is diagnosed when an individual is substance use free, no criteria are met for a period of 12 months or more, again with the exception of craving, so that the DSM-5, in adding craving as a criteria to diagnose, does allow craving to be there once a person enters either early or sustained remission. Craving is seen to be something that can occur, it does occur, and it doesn't necessarily, it's not seen as pathological, although it is something that needs to be looked at and dealt with as far as continued assessment and treatment. It does not take someone out of remission. The last 2, maintenance therapy, again, anyone who's on buprenorphine or any of those related drugs, methadone, et cetera, people that are on maintenance therapy, that would be added as a specifier. and individuals that are in a controlled environment, whether that be a correctional facility. For instance, that would be another example of a specifier. As far as recording procedures are concerned, it's we talked about substance use disorders, and that's how the criteria are laid out in the DSM-5. However, when someone is being diagnosed, you actually use the specific substance that the person is using. So an individual wouldn't be diagnosed with, for instance, a mild stimulant disorder. They would be diagnosed with a specific drug, which would be a mild methamphetamine disorder. As you know, the term addiction and substance abuse, substance dependence are no longer used in recording procedures, although we're fully aware that those words have been with us for decades, and they're kind of hard to kind of get out of our day-to-day talking. But again, as far as recording procedures, you would use substance use disorders. And the term, if a person is using multiple substances, each substance is given a separate diagnosis. The issue of the diagnosis of polysubstance dependence has been removed from the DSM-5, essentially because it was being used incorrectly in the DSM-4, very often being used as a kind of a catch-all category for people that were dependent on one or more substance, and that's not what it was intended for, so it's been removed. There's more written information around that particular issue in the DSM-5 that you can certainly refer to. And last but not least, there are two diagnoses that are new in the DSM-5. We now have cannabis withdrawal, which again is specifically outlined under cannabis. Those signs and symptoms are there. And there's also caffeine withdrawal is added to this particular edition. Again, you're going to be able to look at each one of those 10 substance categories, and under each one of them there will be specific information on withdrawal syndrome if it's there. And hopefully that information on the DSM-5 will be helpful. Thanks, and I'll turn it back over to Bridget.
Thanks, John. Okay, so now we're going to go into ethics. So substance use treatment providers and other mental health professionals are guided by ethical codes of conduct specific to their discipline and practice. And obviously this holds true in the screening, assessment, and treatment of the impaired driving offender. DWI offenders, impaired driving offenders, are coming to you as clients. They have a right to be treated with respect and without judgment. They have a right to be informed of all service fees you will charge. They have a right to privacy and confidentiality. They have a right to decline your treatment recommendations, and they do have a right to be free of discriminatory treatment. So we added this section about ethics, not only because it's important in general to cover, but there certainly are a lot of ethical dilemmas that present themselves when we work with impaired driving offenders. Back in 2006, when we took over the list of approved providers who work with impaired driving offenders, we really learned a lot. We learned a lot about some unethical practices that were happening in the field, and we really felt that we needed to address them, and that's why we added this component to this training. As you know, working with impaired driving offenders, you may have very strong opinions about impaired driving offenders for a lot of different reasons. You yourself may have been impacted by an impaired driving offense in one way or another in your history, and that could impact your clinical services that you provide to impaired driving offenders, and you may not even realize it. So, you know, what we're hoping is that you'll take a look at your attitudes, values, and belief systems related to impaired driving offenders and utilize your clinical supervision on a regular basis to process anything that needs to be processed. And certainly the ethical dilemmas that present themselves need to be processed processed, as well. I remember very vividly, talking about my impaired driving assessments with my clinical supervisor and also with the treatment team, because sometimes it just isn't clear cut as to whether or not somebody needs treatment or not. There's a lot of times when you may be assessing an impaired driving offender and they're not meeting the criteria, but you feel in your gut that there could be something else going on. That's very valid. Impaired driving is a public health concern. So utilize your treatment team, utilize your supervision for that. Because ultimately we want to make sure that the people that need to get into treatment, and the people that don't need treatment don't get recommended treatment. So we as healthcare professionals, I've got to go back to this slide here. The dual role. So it's important to also recognize that while you're working with an impaired driver, you do have a dual role. And the first part of that role is, as the clinician, you're obligated to provide best practices, evidence-based practices, so that your client gets the best treatment possible. The other piece to this is that you do have a role with the public. You need to act in the best interest of public safety, and impaired driving is a public safety risk. So it's really important for you to keep that in mind. You may even want to talk with your client about that, so you're both on the same page with that dual role that you have and how that could impact how you both move forward together. So we work from a multidisciplinary team approach. Healthcare professionals, we all have ethical codes of conduct that we need to follow. There are more similarities than dissimilarities between our ethical codes of conduct. So what I'm going to do now is I'm just going to review what is basically covered in all of our codes of conduct from one degree to another. So non-discrimination is typically covered, rendering responsible treatment, upholding both legal and moral codes of conduct, protecting client welfare, certainly confidentiality, avoidance of dual relationships. So is your client your mechanic? And if your client is your mechanic, should you be working with that person? A statement regarding interprofessional relationships. So what that basically means is you're not discrediting other professions and you're working with other professions in their provision of services. Another important piece to consider is establishing fees and financial arrangements that are fair. So considering the client as you make those determinations about what fees are going to be. And also working with the client from the financial arrangement standpoint. And by financial arrangement, I don't necessarily, certainly if you can offer a sliding fee scale, that's optimal. But financial arrangements also means working with the client to make sure that you are getting paid. Sometimes what ends up happening is that if the client isn't paying you, is that going to be resolved in the end, especially when that person is looking to have their driver's license potentially reinstated by the Department of Motor Vehicles. So it's important to have those discussions up front with the client and to make sure all along you're getting paid so that the client can walk away with what he or she needs, but also you have what you need. Certainly no bounty hunting or fee splitting, And you have an obligation, we all have an obligation to not abandon our clients. It's important to fulfill your promises. One of the ways that you fulfill your promises is by entering information into the impaired driving system in a timely fashion, and we'll talk more about that shortly. Ethical principles that are covered in our codes of conduct are autonomy. The client has the freedom to choose. As I said before, they have the right to choose whether or not they're going to abide by your recommendations, and we have to respect that. Beneficence, which is promoting the client's well-being in everything that you do. Non-malfeasance, avoiding and preventing harm to the client. Fidelity, again, honoring promises and commitments to your client. And justice, clients are treated fairly and equally. And again, you know, getting back to my initial discussion about ethical dilemmas, it's important to, you know, even though the person is an impaired driving offender, they still need to be treated fairly and equally. So here are some ethical red flags that sometimes present themselves in clinical care. Treating clients who fall beyond the scope of one's expertise. Falsified documentation or lack of adequate documentation. So these are things that we look at. When we receive complaints at OASAS, we do have a right to request records. And these tend to be complaints that we get. And we will look at documentation, and we are requiring that all of the documentation is contained in the file. So if we see that things are missing, or if we see that all of the pieces of documentation that are required for the multi-method screening or assessment are missing, we are going to have a discussion about that. Quid pro quo arrangements with referral sources or kickbacks, that's obviously a problem. And extending treatment beyond clinical necessity. And I'd like to add to that that I always get concerned when I hear that impaired driving offenders have to attend a 6-week or a 16-week program. To me, when I hear that, I feel like it's more of a cookie cutter approach, and I think what's important for your client to know right up front is that you are going to be individualizing his or her treatment plan based on whatever their needs are, rather than quoting a certain number of weeks or months that he or she is going to be in treatment with you. And fraternizing with clients is definitely another red flag.
If I can say one thing.
Sure.
Relating to fraternizing with clients, one of the things that we're traveling statewide and training at this point is new ethical dilemmas in the digital age. With all of our technology that a lot of us use in our personal life, it's entered the world of addiction services and has started to create some problems. It's, and again, it comes off fraternizing with clients. Mm-hmm. So one of the things that it's important to pay attention to, it's a supervision issue, is that it's important to not socialize with clients. As we talk about the digital age, one of the things that we're all aware of is social networks, and social networking is a form of a social relationship, and social networking with clients that are in treatment is not something that's acceptable. It's an extension of a social relationship, and there have been addiction counselors in New York State that have lost their jobs related to their social networking with patients, as far as communication, exchanging photographs, all kinds of personal information. And again, that's not appropriate in our field. So that, again, is one thing that we are training at this point actively across the state. And again, it's a clinical supervision issue. We think it's important. There are programs that have developed written policy around digital technology, and we do believe that that's important as far as supervision and coming up with policy around that, so that staff are educated and clear around the boundaries related to digital technology and how they apply to patient care. Thanks so much for adding that piece, John. You're welcome. Okay, so confidentiality, I know we're all aware of how important confidentiality is to our clients. Substance use records are covered under 42 CFR Part 2, which is more stringent than HIPAA. Our clients really need to be aware of their confidentiality.
They come into treatment with us, or they come in for an assessment, and they are required sometimes to fill out 20 different forms, a lot of which are consent forms. It's really important that they understand what they're signing, that you take some time to make sure that they understand it. And it's also important for them to understand what limits to confidentiality are. So having that discussion with them about what's going to happen, what type of communication are you going to have with their probation officer. That's very important for them to also understand. Clients also have to sign an IDS consent form, which is going to allow you to input their information into the impaired driver system. The consent form is on our website, and again, there will be some links at the end of this presentation that are going to point you in that direction to obtaining the IDS consent form. Of course, that can be requested from OASAS at any point in time. So relevant consent documents, this is really more of a review slide for you, but certainly all of your consent forms have to be in compliance with 42 CFR and HIPAA. Your consent forms have to be accompanied by the redisclosure of information concerning alcoholism, drug abuse patients. Both of these forms are on our website, and then again, the IDS consent form. Now I'm going to hand it over to John to talk about treatment and referral.
Thanks, Bridget.
Sure.
So individuals, once they go through your assessment, some of those individuals will certainly be in need of treatment and or referral, and that's what we're going to talk about. So assessment and diagnosis are a prelude to effective treatment referral. The assessment will lead to a diagnosis, and it's important that a referral to the appropriate level of care is made. As you're aware of in OASAS programs at this point, the new locator is now available. The level of care for alcohol and drug treatment referral is available in electronic form. It's no longer paper and pen. And that particular digital document can be used across a variety of platforms, including desktops, laptops, notebooks, etc. The new locator was developed by OASAS in conjunction with CASA Columbia, the National Center on Addiction and Substance Abuse at Columbia University, and it was designed, built, and tested as a web-based tool by Columbia. A lot of the research testing was done by Columbia. So some of the goals for the locator that were reflected was that it be user-friendly. And as far as staff using the locator, it's a tool that can be used, usually averaging in 8 to 10 minutes, so it doesn't take a long time to complete. It's also patient-centered, so it's based on, as Bridget was talking about, individualized clinical assessment. It's also recovery-oriented with inclusion of recovery concepts and encouragement of the use of community and family supports. It also supports the logic supports the principle of least restrictive setting, although at the same time, if you believe and your team believes that a person is in need of a higher level of care, that is something that can be dealt with within the locator. It's also relevant to New York State, so it includes level of cares known and understood by New York State and known and understood by the insurance companies, managed care, managed Medicaid. It's reliable, so it's predictable, and it accurately recommends the best level of care. It's credible as far as managed care plans and substance use treatment providers both use the tool, know what the tool is, accept the tool, and agree that there is evidence to support the tool. And there's clinical support around it. It provides information to clinicians to support the level of care decision to payers and auditors. So level of care, as far as this tool is concerned, is determined by a variety of factors, including diagnostic information gathered through the diagnostic process using the DSM-5, although it's not based on the DSM-5. It does take a look at, we need to bear in mind criteria met. It also assesses the client need for crisis or detoxification services. For instance, determining possible medical complications for withdrawal. So it's important to not to make sure that you answer those questions so that the logic path will take you in that direction. It also takes a look at risk factors such as the presence of severe medical or psychiatric conditions. And lastly, takes a look at resources available to the clients, for example, social or family networks who are supportive toward that individual's recovery goals. So I'll turn it back over to Bridget.
Okay, thanks. So you may be wondering, how does information get to the clinical provider, or from the clinical provider to DMV, and that is through the impaired driver system. So we are now going to talk about the impaired driver system, and usually when I do this training, people are most interested in this piece because they're curious about it. So as I had indicated before, the impaired driver system is an electronic reporting system. DMV is no longer using those old DS-449 forms. Using the IDS, if you are working with impaired driver offenders, is a requirement. It just needs to be done. So basically, the IDS is a way of collecting data, and it tracks motorists charged or convicted of an impaired driving-related offense as they move through the process of screening, assessment, treatment, and participation. It should be and/or participation in the IDP, which is the Impaired Driver Program. So something to highlight here. You have to report in the IDS system if your person is charged or convicted. So basically, sometimes what happens is an IDS consent form isn't collected because the client may not reveal that they're an impaired driving offender, or there could be a lot of reasons for why that doesn't happen. But it's really important for you to ask all of your clients if they do have an impaired driving offense in their history, especially a recent one, because if they do, you're going to have to report your information into IDS so that they can or may eventually get their driver's license back. If the information is not reported into IDS, the Department of Motor Vehicles has no way to verify whether or not the client did what they needed to do. So I think it's good practice, if you're not already doing this, to ask all of your clients about their status with impaired driving, and to get that consent form signed right up front if they are an impaired driving offender. And it doesn't matter where they are in that process. They could have gotten an impaired driving offense yesterday and decided to come into you to try to head off some of the things that they might need to do. You still need to gather that information and report it. So it's a comprehensive database for OASAS and DMV to use in evaluating offender outcomes. It does help us monitor provider compliance with clinical standards, and as I said before, it is mandatory. Basically, what's required, what's reported in IDS is verification that you collected the information that we want you to collect when you're doing a screening or an assessment of an impaired driving offender. When you go into the IDS system, you are going to attest to the fact that you have a signed IDS consent form. You're going to reference the referral source. You're going to indicate whether or not the urine drug screen was positive or negative. You are going to indicate that you checked collateral contacts or that you did not. And then you're going to enter information about the date of the assessment, the end of the assessment, whether or not you recommended treatment, admission, discharge dates, and all of that good stuff. The IDS system is a secure system. You have to be given special access to the system. You have to, you need to supply us with an IRM 15 form. you have to send it to OASAS. And again, we will verify that you've watched this webcast and that you passed the test. After those things have been done in a week or two, you will be given a username so that you can start to enter information into IDS. Here's the box that you'll see. This is a print screen of the box that you'll see when you enter IDS that is basically you attesting that you have a consent form signed. Obviously, if you don't, you should not be going into the impaired driver system, and you need a consent form signed for each impaired driving offender. Who are the user groups? So who uses IDS? You as the provider are going to use it. The impaired driving programs will use the system to view, create, track, and share information to DMV. Basically, the impaired driving programs will monitor IDS to make sure that the motorist is in compliance. For example, if they referred them for an assessment. DMV uses it for relicensing purposes, and obviously they monitor the impaired driving programs through the system. And then we, OASAS, will use it to analyze data and to support outcomes. This system was developed so that we can run reports, different types of reports that New York State has not ever been able to run, linking impaired driving situations to treatment outcomes, assessment outcomes. When we look at the system, we don't see names in the system, and I'm speaking from OASAS's standpoint. We see driver's license numbers, and I'll talk about that driver's license number in a minute. Again, I think the important point, I've covered most of this information, but just a reminder that you are able to view the driver's abstract through the impaired driver system now, which is very convenient. So again, we're going to be connecting recidivism data to prior referrals and or completions of treatment, providing data analysis reports for identifying patterns or trends in caseloads. So we can, through IDS, pick up on provider trends. We can tell, you know, how many times treatment has been recommended versus not recommended. We can identify whether or not urine drug screens are being collected. So we do that for compliance reasons, primarily when we get complaints. So you'll be entering any screening, assessment, or treatment information into the system. And the important thing is to highlight here, and it is highlighted on the slide, is that you are obligated to enter information into the impaired driving system within 3 business days of the event. And you need to update it within 3 business days. So for example, the day somebody comes in for an assessment, that date needs to be entered into the system. And then when you complete the assessment, within 3 business days, the assessment completion date needs to be entered with a recommendation or no recommendation for treatment. The reason why that requirement is there is because impaired driving is a public health risk. So for example, if you have a client who doesn't complete their assessment with you, or if you have a client who doesn't complete treatment or is administratively discharged, it is possible that they could be on the roads driving with a conditional license still if their information has not been inputted into IDS. It's extremely important that you enter this information. And then on the flip side, with a client who's done everything he or she should do and they've successfully completed treatment, if you don't enter that into IDS, they're not going to be able to potentially get their driver's license back. So you're holding them back in a situation where they don't deserve it. And actually, that's unethical. So we do require that you do that. We do look to verify whether or not providers are doing that. And you know, if you're not entering your information regularly, you are at risk of being removed from the list. There is a function in IDS where you can review your open cases on a weekly basis to make sure that they're up to date. We would appreciate if you would do that so that, again, you have a checks and balances system in place for this. So now I'm going to take you to some print screens so that you know how to access the IDS system. Basically, what you're going to do is you're going to go onto our website, www.oasas.ny.gov. And on the top here, you're going to see this purple banner that I call it a banner. I don't know if that's what it's really called. But you're going to click on Services, and then you're going to see this drop-down table, and you're going to select DWI Impaired Driver. And from there, that's going to bring you to our Impaired Driver Services webpage. Now, there's a ton of information on this web page. You're going to see information for impaired driving offenders. You're going to see information about the impaired driver system. You're going to see information for approved providers, so that would be you, and information for the impaired driver programs. To access IDS, you're going to actually go over here where it says log in to the OASAS client data system and click on that. This screen is a little blurry and I apologize for that, but you're going to notice if you look down where this yellow area or arrow is, the tab underneath it says online tutorials. There are some very short, quick tutorials that are available on our website. So as you are getting your approval to use the IDS, after you get that approval, please look at the tutorials. There is a manual. It's probably about 50 pages long. I would suggest you look at the tutorials first, refer to the manual as needed, and then call us after you've done those two things. So you would click on this tab, Online Tutorials, and that's going to bring you, if you scroll all the way down to the bottom of this page, you're going to have a number of tutorials that you can take a look at. There are some tutorials here for impaired driving programs, also known as the DDP programs. You don't have to look at those tutorials. So to actually go into IDS and enter your information, you are going to go back and you are going to select this tab over here, which is the Applications tab. And then you are going to select over here, Impaired Driver System by the second yellow arrow. And that's going to bring you into IDS. And this is the page that you'll see, and I was referring earlier to the driver's license. We call it the CID or the client ID number. That's basically, we all have a driver's license number. The first thing that you're going to do is you're going to enter that driver's license number into the system. And when you do that, it's going to populate. But again, you're still going to have to attest that you have a consent form signed before you go further. Okay, so when the screen populates, this is what you're going to see. You're going to see at the top the client ID number, birth date, the first two characters of their last name, and other information. Oh, sorry about that. And underneath, you're going to see information. So this person had an assessment by John Doe on this date. And then underneath it says that the person had an assessment with John Doe and the referral source was from the court, and then there's corresponding dates here and that the treatment was recommended. So then if you want to open up more information about any of these details, you would click on Details. So this is what you'll see when you click on Screening Details. You'll see information about the provider, the program, and then the information relating to the motorist. Similar to that is the screen for the assessment details, where the motorist information is on top, the provider name is up here, and then referral source is listed to the left with the additional information about the multi-method assessment that we talked about earlier. And again, here are the treatment details that you would see. This is more of an FYI page for you. This is what the impaired driver programs will see in the impaired driver system when they go in on their end. There are going to be occasions when you will type in the driver license number or the client identification number and nothing comes up. The reason for this is because the impaired driver system is a point-forward system. So it was launched in 2013, meaning that there is not information prior to 2013 in the system. So as the years go by, more and more impaired driver information will be in the system, but certainly you're going to run into situations where the information about the motorist does not pop up. So there is a tutorial about how to create a case. And I'll just really briefly review that. Essentially what you would do is you would go into general and you would enter the information into this area here about the motorist, and then you do have to insert violation information into the system for the information, for a record to be generated essentially. So you're going to click on the insert violation tab and enter that information in. So here are some important reminders that we just want to close with. Again, all clients presenting for an assessment with an impaired driving offense should be asked for or should be asked to sign an impaired driver consent form. It's going to prevent a lot of headaches for you if you do get this information up front. There's no need to complete a screening for a client unless it's mandated by a judge. Treatment can only be recommended if the client has a DSM-5 diagnosis. We do understand that you're going to run into situations with clients where you're going to feel like there's something else going on, but for whatever reason, the information isn't there to give the person a substance use disorder. Sometimes what providers like to do is they like to tell the client that they need to attend some educational sessions before they enter the information into the impaired driver system. That is wrong. It should not be done. We hear about this all the time. So in these scenarios, what happens is after you complete an assessment, if they don't meet diagnostic criteria, you should be entering into IDS no treatment recommended. If you want to give other recommendations, such as education or other things that the motorist you believe should do, you can give those recommendations, but they're not mandates for the client or the motorist to carry through. As I had just talked about, all information does need to be inputted into IDS within 3 business days. And again, please check your open cases on a weekly basis so that you know what needs to be updated. It's a great checks and balances for you. So here's our contact information. I do ask that before you call us, please look at our website. We have a lot of information that's on our website that can probably easily answer your question. You can check out our frequently asked questions section of our website. Certainly though, if you need to call us, you can send us an email at this email address or contact us using this phone number. And here are some additional web links for you where you can just learn more about impaired driver services, get the the consent forms that you need. The link to the frequently asked questions is right there for you. So I think that that is all of the information that you would need if you wanted to contact us for any reason. And so at this point, we are finished with our presentation. I would like to thank you for your time and attention today. We do appreciate it. And at this point in time, I think Patty is going to close things out.
Hi, this is Patty again with a thank you to both John and Bridget for the presentation. And to our viewers, as you can see, your feedback is appreciated. So if you could take a moment to fill out a brief survey, again, we would appreciate it. Thank you all for joining us. Enjoy your day, and bye for now.